Hello everyone and welcome to this video. This video is on trigeminal neuralgia and everything you need to know about it. So let's get started. Now coming to the word neuralgia. Algia comes from a Greek word algos referring to pain. So neuralgia can be defined as the pain along the distribution of one or many nerves. The most common site for neuralgias being the head and neck region. Under the general heading of neuralgias, we have different kinds such as the trigeminal, occipital, glossopharyngeal, postherpetic and intercostal neuralgia among many. And the one of our concern in this video is the trigeminal neuralgia. Now, trigeminal neuralgia is considered to be one of the most serious and the most common of the facial neuralgias, characterized by an extremely severe electric shock or lancinating pain. So here you would see that when the patient is asked to describe what kind of pain he's suffering from, he would use the words such as an electric shock, or he would tell you that it feels like something is piercing him or something is stabbing him, and those are indicative of a lancinating pain. So anytime a patient tells you or describes you of a lancinating pain, it should immediately ring a bell of nerve irritation, right? Apart from that, we see that the pain is limited to one or more branches of the trigeminal nerve. Now, this is indicative of the lancinating pain. Apart from that, as I told you, it is limited to one or more branches of the trigeminal nerve. Now we know that the trigeminal nerve is the fifth cranial nerve and it has got three divisions, which are the ophthalmic, the maxillary and the mandibular. And in this picture, you can also see the area of distribution. Now in trigeminal neuralgia, the mainly affected divisions are the maxillary and the mandibular, and only about 4% of the cases have the involvement of ophthalmic nerve alone. Now, coming to something important that I want to mention before we move on to the clinical features. Trigeminal neuralgia is also known as the suicide disease, and the significance of this is underscored by the fact that it has one of the highest suicide rates of any disease, and it is regarded as one of the most painful afflictions known. Eminent people such as Indian film star Salman Khan and entrepreneur and author Melissa Seymour, among others, have suffered from this and have brought awareness regarding this disease. Now, the reason for me to mention this is the importance of us as doctors to be able to understand and diagnose this disease as well as to be able to differentiate it from other diseases, right? So now, the other names of this disease include trifacial neuralgia and Fothergill's disease. And apart from that, it is also called tic douloureux. Now, tic douloureux is a word that is derived from the painful jerking that is observed, okay? There are spasmodic contractions of the facial muscles which may lead the patient to clench the hand over the face because it is associated with severe lancinating pain, right? So there is spasmodic contractions of the facial muscles which are associated with lancinating pain, and often the picture is depicted to us in a way that the patient may even clench his or her hand over the face. So coming to its etiopathogenesis. Now coming to the etiopathogenesis of trigeminal neuralgia, it is largely unknown and it is usually idiopathic with no definite etiology. But often it is thought to be because of the compression of the trigeminal nerve by blood vessels. So this could be due to vascular abnormality leading to nerve compression because of enlarged or lengthened artery. In other cases, it might also be due to an aneurysm or atriovenous malformation. It might also be due to petrous-rich basilar compressions and due to compressions by intracranial tumors. All of these can injure the myelin sheath which is present around the nerve, and this can lead to hyperactive and erratic functioning of the nerve. Okay, so the basic etiology is nerve compression due to vascular abnormality, and in more rare cases, aneurysm, atriovenous malformation, intracranial tumors, which cause the demyelination of the nerve. Now, apart from that, we have an autoimmune condition also, which is multiple sclerosis, which can cause demyelination of the nerve. It might also be related to post-traumatic neuralgia and trauma due to dental etiology. Moving on to the clinical features, what we see is that its incidence is about 8 in every 100,000 individuals. Now this may vary from countries, such as in USA it is 5 to 4 cases per 100,000, whereas in the Europe it is reported to be much higher, almost 20%. Okay, so we take an average of 8. The age, it is more common in older individuals, which are in above 50 years of age, and more commonly in females. The affliction is more for the right side, and in most cases it is unilateral with an affliction towards the right side. Apart from that, it is more commonly associated with the mandibular and the maxillary division of the trigeminal nerve, and only about 4% cases where the ophthalmic nerve is alone involved. Now, one thing I want to mention here is that bilateral involvement is usually rare, and it may be associated with multiple sclerosis. And in multiple sclerosis, younger individuals as well tend to be affected. Okay, so we saw that it is more common in older individuals, especially females, with an affliction for the right side involving mainly the mandibular and the maxillary division. Now coming to the presentation of the disease. In early stages, it is a rather mild pain. So the patient will describe it to be sort of a twinge, dull ache and a burning sensation. At this point, it is very easy to mistake it for a pain attributed to teeth, jaws and paranasal air sinuses, and this may lead to inappropriate treatment. Further, with the progression of the disease, attacks begin to occur at more frequent intervals and the pain becomes increasingly intense. At this point, the patient begins to describe it to be an electric shock or something like a bolt of lightning or being stabbed by an ice pick. We also see tic douloureux that gets talked about, which are spasmodic contractions of the facial muscles associated with pain. Okay. The characteristics of this pain are that the painful episodes last for a short duration and are followed by a refractory period. That means that during a painful episode, following that there is a refractory period. So in this refractory period, further stimulation of the trigger zones will not elicit another attack. And this is useful for clinically distinguishing it from provoked odontogenic pain. So we saw that in the early stages, it was sort of a dull ache burning sensation. With time progressed into increasingly intense pain at frequent intervals. Here it is described as stabbing, lancinating pain, initiated when a patient touches a trigger zone, followed by a refractory period during which stimulation would not elicit another attack. We also saw that the presence of tic douloureux, which are spasmodic contractions of facial muscles associated with intense pain. Now coming to the trigger zones and the trigger points that we had talked about earlier. Now there are certain zones that are present along the distribution of the nerves, which when stimulated will elicit an attack of trigeminal neuralgia. So in the V2, which is the maxillary division, this is near the skin of the upper lip, the ala of the nose, the cheeks and the upper gums. In the mandibular division, it is the lower lip and the gums of the lower jaw. And in the ophthalmic division, it is the supraorbital ridge of the affected side. So the pain can be caused by a stimulation of any of the areas of the sensory distribution of the trigeminal nerve. Apart from that, sudden onset of pain will occur following mild stimulation of these areas, and the activities can be as simple as washing your face or eating or brushing the teeth or even being exposed to a breeze. Now this is understandably the cause of trauma to these patients, and they begin to avoid these day-to-day activities, fearing the onset of another attack. Now something I want to mention here is the necessary criteria for diagnosis of trigeminal neuralgia, which will be sort of a revision of what we have studied so far as well. The onset of pain is abrupt, often initiated by a light touch to the constant trigger point. Pain is extreme, paroxysmal, and lancinating. Duration is less than 2 minutes. Now what I want to mention here is the necessary criteria for diagnosis of trigeminal neuralgia. This is sort of also a revision of what we've studied so far. In classical trigeminal neuralgia, the attack is abrupt and may be initiated by the touch of a constant trigger point. It is often extreme paroxysmal lancinating and includes repeating spasms of short duration, which are followed by a refractory period during which the stimulation of another trigger point will not elicit another attack. Apart from that, the pain must be limited to the known distribution of the trigeminal nerve with no motor deficit in the area, and it is dramatically diminished, at least initially, with the use of carbamazepine. Now, this is an anticonvulsant drug which is used for the treatment of trigeminal neuralgia as well, and it is often, in about 80% of the patient, it provides relief. Apart from that, spontaneous remissions occur, often lasting more than 6 months, especially during the early phase of the disease. Now, coming to the differential diagnosis of trigeminal neuralgia, the first one we have is migraine. So here in migraine, the pain is often persistent for hours and there is not a presence of trigger zones along the face. Apart from that, we have sinusitis, which is the inflammation of the paranasal sinuses, and the Costin syndrome, which also produce symptoms similar to trigeminal neuralgia. We have tumors of the nasopharynx, as you can see here, and in the Trotter syndrome, which is due to the involvement of the mandibular nerve near the foramen ovale, through which the tumor actually invades the calvaria. Apart from that, we have post-herpetic neuralgia, which is due to the complication of the herpes zoster virus. So all of these are included in our differential diagnosis and must be kept in mind before coming to a conclusion. The treatment of Now coming to the treatment of trigeminal neuralgia, this has been often varied over a course of years. All sorts of things such as peripheral neurectomy and injection of alcohol, application of boiling water in the trigeminal nerve root. All of these techniques have been tried over the years and have also provided short-term relief, but here I'll focus on the mainstay of the treatment. So the initial phase is mostly pharmacological, where we use the anticonvulsant carbamazepine or otherwise phenytoin, gabapentin, lamotrigine, etc. In about 80% of the patients, they feel a relief by carbamazepine, and this is often, as I told you, used as a diagnostic test as well in the initial phases of the disease. In the surgical treatment, one of the most popular surgeries is the suboccipital microvascular decompression of the trigeminal nerve root. So as we learned in the etiology, trigeminal neuralgia can be caused by vascular compression as well. And as you can see in this picture, this is the trigeminal nerve which is pinched between two vessels. So surgical management of this includes decompression of the nerve by the application of Teflon between the nerve and the first vessel. Now this is quite an upcoming surgery in these times and may provide relief up to 10 years. Apart from that, our less invasive surgeries involve destroying the affected portions of the nerve through radiofrequency rhizotomy, glycerol rhizotomy, balloon microcompression, and the use of a gamma nerve knife. So with this, we come to the end of the lecture. Let's just quickly revise what we've studied. So the meaning of neuralgia, which meant pain along the distribution of the nerve, the important one in our discussion being trigeminal neuralgia. So we began by talking about neuralgia, which meant pain along the distribution of a nerve. Now trigeminal neuralgia is characterized by severe electric shock or lancinating pain, which is confined to one or more branches of the trigeminal nerve. Apart from that, we saw that it is the disease of suicide, and it is also known as tic douloureux because of the painful jerking, which are spasmodic contractions associated with pain. We saw the idiopathogenesis, which was usually idiopathic, involving the demyelination of the nerve due to vascular abnormalities, or multiple sclerosis and other traumatic injuries. Apart from that, in the clinical features, we saw that it is more common in females above the age of 50 and in the mandibular and maxillary divisions. In the early stages, the pain was dull, ache, burning. With time, the pain became increasingly intense at more frequent intervals. Electric shock, bolt of lightning, being stabbed by ice pick were the kind of descriptions. They were associated with spasmodic contractions such as tic douloureux, and the painful episodes are of a short duration followed by a refractory period. We saw the presence of certain trigger zones involved in the distribution of the nerve, and we saw that these can be triggered by simple activities such as washing the face, shaving, eating, brushing one's teeth. We saw the necessary criteria for diagnosis of trigeminal neuralgia, saw the differential diagnosis which involved migraine, sinusitis, Costin syndrome, tumors of the nasopharynx, as well as post-herpetic neuralgia. And in the treatment, we saw the pharmacological management by anticonvulsants, the surgical management, which included one of the best techniques, which are the vascular decompression, and certain less invasive surgeries such as radiofrequency rhizotomy, glycerol rhizotomy, and gamma knife. So with this, we come to the end of the lecture. Thank you so much for watching, and I hope it helped you in whatever way possible. And if it did, please like and subscribe, and I hope to see you in another video soon. Have a good day.